And I'm not going to present an enormous amount of new data, or in fact any new data at all. The intention really is to give an overview of what is more or less the current state of play in a rapidly changing field, and that is the management of multi-drug resistant tuberculosis. It's more or less up to date because it's soon going to become out of date in the sense that new WHO guidelines on the management of MDR-TB will arise shortly, but I think looking at the current state of play is interesting because it identifies weaknesses in our current approach and perhaps areas of uncertainty which are obviously essential to fuel future research questions and activity, and I will try to focus predominantly on expanding access to low resource settings where able. As we all know, we're perhaps uncharacteristically optimistic at present in terms of tuberculosis control, because in September 2015 the WHO sent us all an email announcing that we had achieved the Millennium Development Goal targets more or less that pertain to tuberculosis. So significant improvements since TB was declared a global emergency in the early 90s, 42% reduction in prevalence and 47% reduction in HIV negative mortality, leading us to the catalyst of this meeting today, the End TB goals, the NTB strategy, sustainable development goals, a launch pad for a much more ambitious target of ending the TB epidemic by 2030. So very, very upbeat. But of course, the speck of doubt and concern on the horizon, or I think one of the biggest specks of doubt in the horizon, is the ongoing emergence and escalation of multi-drug resistant tuberculosis. I'm sure all in the audience know what MDR-TB is. It's tuberculosis active disease that's resistant to the two key first-line drugs, rifampicin and isoniazid. In the 2009 Global Tuberculosis Report, there was an estimated 250,000 cases worldwide. In the 2015 report released just at the tail end of last year, there was an estimated 480,000 cases. So a significant increase in our perceived burden of MDR-TB from a global perspective. Of course, all MDR-TB is not the same, so increasingly we also encounter the problem of disease that is not only multi-drug resistant, but has superadded resistance on top of that. For those who don't routinely treat tuberculosis patients, if we can't use first-line therapy, then we tend to base our treatment on the use of a group 2 drug, which is an injectable drug, amikacin, kanamycin, capreomycin, and a fourth-generation fluoroquinolone, such as levofloxacin or moxifloxacin, and pre-extensively drug-resistant TB is more or less TB in which one of those drug categories is unavailable to you. And then, of course, XDR-TB, extensively drug-resistant TB. Lots of talk about that in Eastern Europe and also in some parts of Southern Africa. Strains of tuberculosis, which are resistant to both an injectable and a fourth-generation fluoroquinolone, particularly bad prognosis, up to 70% treatment failure and mortality in some settings, and cases of XDR-TB now notified globally in more than 100 countries, and some estimates that XDR-TB may account for up to 10% of multi-drug resistant disease, although there are significant information gaps in those projections. But the overall message, I think, is that while we set our NTB strategy with ambitious goals to be achieved in a relatively short time frame, failure to control multi-drug resistant tuberculosis, I think, is already evident and stands as a significant obstacle to be overcome if we're going to get anywhere near achieving those goals. So where does the majority of multi-drug resistant tuberculosis occur? It's a worldwide problem. Currently, we have 27 defined high-burden MDR-TB countries, and that definition is based on at least 4,000 cases of MDR-TB notified per year, and more than 10% of the overall national tuberculosis burden being because of drug-resistant disease. 17 of those high-burden MDR-TB countries are in low or middle-income countries, according to GDP, and those are the red and yellow countries on the map shown on this slide. Even in the higher income countries, which are essentially the Baltic states and Russia, as with all forms of tuberculosis, the higher burden of drug-resistant disease tends to occur in pockets of society which are hard to reach and where resources are less. So across the board, we are looking at the problem of providing what is prolonged, complex regimens of toxic drugs, and that isn't easy, and that really brings us to the problem that I'm going to try and discuss a little bit over the course of this talk. I'm going to focus predominantly on therapeutics, because that was more or less the brief of this session, but there hasn't been a session today dedicated to TB diagnostics and the role of TB diagnostics in reaching the NTB goals. And I think it's important just to pause for a moment and to think about the impact of imperfect diagnostics on the likelihood that we will succeed with improved treatment goals. If you haven't got the right diagnosis, you are unlikely to provide the correct treatment. And in 2013, while we estimate a large burden of MDR-TB globally, somewhere just over 100,000 patients were initiated in MDR-TB therapy. So more than half of patients with MDR-TB do not have the diagnosis made, and that's largely because traditional approaches to identifying drug resistance have, of course, been based in phenotypic drug susceptibility tests requiring culture facilities, requiring significant laboratory structure and taking a long time. So one of the key questions, even before we get to the point of what treatment to give, is, well, the new molecular, or the relatively new molecular tests that we have, the Expert, perhaps Expert Ultra in the coming year, some of the line probe assays that give us quicker diagnostic confirmation of complex resistant patterns, help us bridge the diagnosis gap. And if we can bridge the diagnosis gap, will we then have adequate access to improved treatment regimens to supply therapy to those patients? But of course, as perhaps signposted in an earlier slide, identification of someone with rifampicin resistance on a gene expert assay doesn't tell us the whole story, because we aren't faced more often than we would like with the additional problem of superadded resistance to the second-line drugs that are available to us. So the table at the bottom left-hand side of the slide just points to a publication from Emerging Infectious Diseases last year, a survey of drug-resistant patterns in about 1,300 MDR patients across 9 countries worldwide, and growing problems with fluoroquinolone and aminoglycoside resistance, the 2 classes of second-line drugs that we might standardly turn to if we were to use current WHO approaches to the management of MDR-TB. And that creates a further set of diagnostic questions for us as we decide how to plan MDR-TB therapy. It's not enough to confirm that MDR-TB is there. How do we expand access to second-line drug susceptibility tests in complex settings so that where necessary we can individualize therapy? And after achieving much of the advances that we have in TB control over the course of the last 20 or 30 years by adopting a very low-tech public health approach to giving every patient the same treatment based on the same diagnostic tests, how feasible is it that in low-resource settings we can individualize therapy as necessary to achieve better treatment outcomes in patients who have pre-XDR or XDR tuberculosis? I'm not going to present the answers to those questions, but just want to place the context of ongoing difficulty with diagnostics as a limitation to more effective treatment, even as new drugs emerge from the drug development pipeline. So having been slightly depressing about that, I want to move on to talk about, or to just briefly reprise, currently advocated MDR-TB regimen, which is perhaps soon to be superseded, but I think demonstrates why successful treatment outcomes, as Dave Moore told us this morning, for multi-drug-resistant tuberculosis, completing treatment occurs in less than 50% of patients who initiate it. So currently we group TB drugs into 5 main classes. The group 1 drugs are the first-line drugs that we use for drug-susceptible disease, and rifampicin and isoniazid, at least at normal dose of isoniazid, are out for patients who have MDR. Group 2 drugs and the Group 3 drugs are important in our standard management of MDR-TB. So Group 2 drugs are the injectable agents, amikacin, kanamycin, capreomycin. Currently, we have to give them for 6 to 8 months, and they're associated with significant logistical difficulties and toxicity. The Group 3 drugs, the fluoroquinolones, particularly levofloxacin and moxifloxacin, sensitivity to fluoroquinolones in a patient with multi-drug-resistant tuberculosis is an extremely good prognostic indicator, and so those medications also present the bedrock, really, of standard MDR-TB therapy. We then have to complete a regimen of 4 to 5 medications with the Group 4 drugs, and those are oral bacteriostatic agents, agents that we turn to because we haven't really got anything else. Generally, prothionamide or ethionamide, cycloserine, and PAZ. They're bacteriostatic, they're not tremendously efficacious, you have to give them for a long time, and they're not particularly nice to take. So we use those medications reluctantly. And then we move down to Group 5, where we can't put a regimen of 4 to 5 medications together using drugs from Group 2, 3, and 4. We're advised by the WHO to use Group 5 drugs, and those are drugs where there is limited data to support efficacy or safety. But in fact, I'm predominantly going to talk about drugs in Group 5 today because the top 4 drugs on the list on this slide, Bataclan, Delamanid, Linezolid, and clofazimine, I think are agents where the evidence of efficacy is significantly increasing, where we want to turn to them more readily, and where in fact they're probably better than drugs in the current Group 4 category and are going to become a more regular part, I hope, when the new MDR-TB guidelines come out, of how we manage this disease in the clinical setting. How do we use that pharmacopoeia at present? Well, just like drug-susceptible tuberculosis, we manage MDR-TB essentially in 2 phases, an intensive phase and a continuation phase. The intensive phase of therapy tends to go on for around about 8 months, certainly till at least 4 months after culture conversion in a patient who was sputum culture positive at baseline. We use at least 5 drugs which are judged likely to be effective, and we try to use an injectable agent throughout that 8-month period, an aminoglycoside or capreomycin, and then a continuation phase where we essentially continue all of the medications, provided they're still tolerable, for a period of something like another 12 months, given a total duration of therapy of 18 to 20 months, in order to hopefully achieve relapse-free cure. So what are the problems with that? Well, perhaps the problems with that are obvious, but as we think about the new agents, it's perhaps useful to have them at the front of our minds so that we can evaluate how the new medications are going to help us. Well, the first problem is that even with a treatment plan such as that, there is a significant degree of attrition between the diagnosis of multi-drug reverse tuberculosis and initiation of therapy. So I've already spoken about the treatment gap in patients where our diagnostic tools do not identify the disease. There is a second level of attrition in patients who are diagnosed but never access effective MDR-TB treatment. In 2013, it was estimated that in 10 of the 27 high-burden countries, less than 60% of patients who even obtain a diagnosis initiated treatment. And that's partly because of poor access to second-line drugs, it's partly because of the cost of effective MDR-TB treatment, and it's partly due to a number of logistical factors. Patients who initiate therapy find the intensive phase of treatment difficult, and indeed healthcare practitioners, particularly in low-resource settings, find administration of 8 months of daily injections difficult to deliver. There's significant toxicity associated with the injectable agents, predominantly centers on nephrotoxicity and ototoxicity, which is not surprising for aminoglycoside therapy. And somewhere between 20 and 60% of patients, even if they do well in terms of their MDR treatment regimen, emerge from that period with some degree, often of quite profound hearing difficulty. Capreomycin might be a bit less toxic. There might be some things we can do to ameliorate those side effects, and there's discussion of N-acetylcysteine and other agents, but this profound ototoxicity of the injectable agents is a significant problem to success of therapy. And then if we get through the intensive phase of therapy, the continuation phase is too long. So data from Eastern Europe, from Ukraine, suggests that even in relatively well-functioning programs where you get up to 70% of patients to 8 months with your daily injection, once they're free range in the community, taking oral medications, which are nausea-inducing, some of them have psychiatric side effects, some of them induce significant peripheral neuropathy, sometimes you only get a quarter of patients to the end of treatment. So we need to get rid of the injectable, and we need to make the total duration of treatment shorter. And of course, it's well described that tuberculosis, particularly in southern Africa, closely associated with other chronic diseases such as HIV, and in other parts of the world, the growing burden of TB diabetes is perhaps a similar type of phenomenon. Giving lots of medications for a long time creates the issue of polypharmacy, creates the issue of overlapping toxicity, and creates the issue of drug-drug interactions. And so when we think of a program to improve access to effective MDR-TB treatment in the low-resource settings, the obvious messages, and they're probably intuitive to this particular audience, so I apologize for repetition, is that we need shorter treatment, we need all oral treatment, we need less toxic treatment, and we need medication that we can give without significant drug-drug interactions. There are 2 potential approaches towards that kind of aim. We could take the drugs that we already have, and we could combine them in different ways to see if we end up with a better outcome. Or we could say that the drugs that we already have by themselves are not good enough, and we could add new medications to them. And both of those strategies have been considered over the course of the last few years. The way of mashing up the drugs that we already have and combining them differently has sort of coalesced into what's loosely referred to as the Bangladesh regimen or Bangladesh-style regimens, based on a series of cohorts funded by the Damien Foundation, run in Bangladesh, where larger combinations of second-line antituberculous drugs were given to patients for a shorter duration of time to try and improve cure rates. In 2010, they published this regimen, that's 7 drugs, including the injectable, for a period of 4 months, slightly longer, as sputum smear conversion has not happened in that time frame, followed by a 5-month continuation phase of 4 drugs. It's a lot of medicine to take, but with much, much better outcomes than have been previously reported for standard optimal baseline WHO regimens. Relapse-free cure up to something like 90%, and then more recent updates to publications on this cohort follow up to something like 24 months after completion of therapy. The authors and proponents of that regimen tend to highlight 3 things when they talk about it. It's very difficult to say which of the drugs are doing most of the work. If you give everybody 7 drugs at baseline and the patient does a bit better, it's a bit hard to say which drug was the workhorse of the regimen and which one you could have done without. But the authors tend to highlight the use of 4th-generation fluoroquinolones, and they used a high dose of gatifloxacin in this particular regimen, and the use of the rehabilitation of clofazimine, a slightly forgotten drug that I'll talk a little bit later on, as being key drivers of better outcomes after shorter treatment in this regimen. They also highlight, and it's important for a talk on resource-poor settings, that these patients were followed up under routine conditions, and that because they used old, off-patent, easy-ish to access medications, the cost per patient, of the regimen was very low. Unsurprisingly, people who read that data were enthused by it, and a number of other countries, predominantly across Africa, have either tried to introduce the shortened MDR Bangladesh-style regimen or proposed to do so. And as of 2013, so it's a little bit out of date, the countries on this slide are those who were most advanced in trying to adopt that approach. Data from one of those countries, Cameroon, was published in the Union Journal last year, and it was remarkably similar to what the Bangladesh cohort described. Follow-up up to 24 months after completion of treatment, almost 90% relapse-free survival. Slight differences in the regimen. They used a lower dose of gatifloxacin because they were worried about fluoroquinolone toxicity. It does prolong the QTC interval. It may create a risk of arrhythmias. They didn't use high-dose isoniazid. They just used standard dose in the regimen. They didn't have the option of giving treatment for 9 months. It was 12 months for everyone. And they continued an additional drug, a group 4 drug, prothionamide, throughout the continuation phase of treatment. But those changes notwithstanding, it was the same type of regimen. It was 12 months rather than 20 months, and it presented the same kind of cure rates. So you might say, sit down now, problem solved, we're all just going to use that. There are concerns, however, about broader implementation a priori of the Bangladesh regimen. There is limited evidence of efficacy. It has not yet data has not yet been published to show the efficacy of this regimen in a regulated phase 3 clinical trial. So we're limited still to a relatively small amount of cohort data. And we clearly are giving large combinations of potentially toxic medication. What the WHO say at present, although they may be going to say something else relatively soon, are that if a national TB control program in a resource-poor country wants to use a Bangladesh-style 9 to 12-month regimen, then they should only consider doing so effectively by conducting an operational research project. It's an experimental regimen. It has to be approved by national ethics committees. It has to be delivered under operational research conditions, and the delivery of that program should be monitored by someone independent with the data reported to the WHO. And to try and test the regimen more, the Union sponsored a STREAM trial, which is a direct head-to-head comparison, really, of a Bangladesh-style regimen. They've made some further modifications. They've taken away gatifloxacin because of toxicity concerns and risk of hyperglycemia and replaced it with moxifloxacin. But otherwise, a Bangladesh-style regimen trialed against current standard WHO treatment for MDR-TB in a series of several countries, and they'll tell us how that went, at least the first phase of that study, hopefully sometime next year. So that's where we are with this type of shortened regimen. It's possibly a bit better. We're a bit lacking in evidence, but we'll have more information relatively soon. Even if it works really well, We unfortunately can't stop the talk there, and that's not just because the next speaker isn't here. We can't stop the talk there because there are limitations to how well the Bangladesh-style regimen is going to perform. It still remains reliant on injectable therapy for the first 4 months of treatment, and we want to get rid of the injectable because it's a pain to give, both for the recipient and the provider, and because it's associated with toxicity. The regimen is heavily reliant on fluoroquinolones, so patients with pre-XDR tuberculosis, for instance, or with the gyrase mutations that confer fluoroquinolone resistance, very few of them have been included in the cohort studies of Bangladesh-style regimens. Those that have tended to do less well than the cohort as a whole. So even with all of those drugs, it may not be effective in patients with key additional pieces of resistance. And so, irrespective of how good we think the Bangladesh-style regimen is going to be, I would still stand by the statement at the bottom of the slide. We urgently need MDR and XDR-TB regimens which use some existing agents but do incorporate entirely new anti-TB compounds. So turning then to either new, repurposed or rediscovered drugs, which sort of is what the current group 5 drugs are, perhaps the medication that's generated most interest so far is the introduction of Bataclan. So Bataclan is an oral agent, so it takes away the need for an injectable, perhaps. It has a new antibiotic target compound. It's the first compound to be licensed for clinical use with a new target against M. tuberculosis for over 50 years. It inhibits mycobacterial ATP synthase. It's bactericidal against replicating and non-replicating bacteria. So that means it may be effective against the type of persister bacteria that survive for a long time and necessitate a very long duration of treatment for MDR-TB. And it is effective, at least in phase 2 studies, against drug-susceptible and drug-resistant disease. A curiosity, perhaps, during the period of Bataclan drug development was that in early bactericidal activity studies, so for those of you who don't do TB pharmacology, essentially we give the drug for very short periods of time, 2, 7, or 14 days, and we look at the speed at which the bacterial load falls over that time period. It didn't look like it was working very well at all for the first 4 days of EBA studies, and then it started to show good efficacy thereafter. And that's perhaps because of the amount of time it takes to accumulate intracellularly to inhibit the ATP synthase enzyme. But it's also a warning that EBA studies of very short duration are not necessarily a good way to test anti-new TB compounds because it took a little bit of a while for Bataclan to show its effect. But back from the research environment to the clinic, phase 2 more extensive trials of efficacy in Bataclan were interesting. So how was it initially used in those studies that were conducted over the course of the last few years? Well, there are 2 key studies, TMC-203 and TMC-204. Optimized background regimen, so people still getting the standard WHO regimen I illustrated a little bit more comprehensively a few slides ago, supplemented either with placebo or with Bataclan for the first 6 months. The graph on the left-hand side of this slide shows the time to sputum culture conversion. So patients all sputum culture positive at baseline, and then the time until there was no longer culturable tuberculosis from the sputum of those individuals. Patients who had Bataclan added to the optimized background regimen obviously did better. When, after 6 months, Bataclan stopped, standard therapy continues out to the end of what would be a normal course of 18 to 20 months of TB treatment, and what were the final outcomes? And this is interesting because by and large, as you might expect from the early signal, those patients did better. Treatment completion rates were slightly higher. Sustained cure rates were certainly higher, 58% versus 32%. But a slight twist in the tail because more people who had received Bataclan during these phase 2 studies had died during the period of follow-up than patients who had received placebo. It was 12 patients versus 3. The deaths didn't seem to be attributable to the study drug. It's probably an incidental signal, but a slightly higher mortality rate in the study drug is not what you want to happen when you're conducting a clinical trial. Nevertheless, the overwhelming evidence of efficacy and the need for new compounds against multidrug-resistant tuberculosis led the FDA to provide a conditional license for the use of Bataclan in the management of MDR-TB. WHO have issued guidelines on the use of Bataclan in the management of MDR-TB, and a large number of compassionate release programs worldwide have brought about an emerging experience of the drug in a variety of settings. And I think overall we're more than cautiously optimistic about how Bataclan is performing. I guess, as with the Bangladesh regimen, we don't actually know what the final answer on Bataclan is. It does speed up culture conversion in the first 6 months. If you give a standard 18 to 20-month course of MDR-TB treatment, you are more likely to be cured. But could we stop treatment a bit earlier in that case? Could we abbreviate the continuation phase of therapy in order to not only have an all-oral regimen, but to have a regimen in which we can stop after 6 months, 9 months, 12 months? We don't know the answer to that yet. And so the STREAM study, which will report phase 1 in 2017, has now added 2 additional arms to the trial, both of which contain bedaquiline, a 9-month arm in which kanamycin's out, and it's an entirely oral course of therapy, and a 6-month arm in which the injectable is retained, but the duration of treatment is shortened and bedaquiline is added. And that's the kind of data I think that will tell us whether bedaquiline really is a genuine treatment-shortening agent for multi-drug-resistant tuberculosis. But that phase of the STREAM study is not going to report until 2019 or 2020 or something like that. So we're a few years away from having that data. Bedaquiline is also included in emerging protocols. There's a large number of phase 3 clinical trials in MDR-TB, all of which are bewildering acronyms, and none of which I'm going to try and remember in detail today, but a drug that's increasingly available to the clinical trials network. And conducting those trials is a little bit interesting because we have bedaquiline. I'm going to tell you about some other new drugs. There are lots of existing second-line drugs. How do we know in which combination to put them together in order to achieve maximal efficacy? And the notion is that we have to try more than one of them. So we have to try drug combinations where we're giving 4, 5, 6 different combinations of therapy at baseline. And so some of the newer trials of MDR-TB have adopted more innovative trial designs, things like the multi-arm, multi-stage design. And I will just mention that briefly in passing because it's pertinent to the demand for new MDR-TB treatments, is that we need them soon. So we can't conduct a series of 2-arm studies just to see which one's ultimately going to be best. We're going to have to be a little bit more imaginative than that. And so building from the world of clinical trials in oncology and cancer therapy, multi-arm, multi-stage trial designs are becoming more common in TB studies, where we start lots of regimens and where we have the power at various points of interim analysis to stop the ones that are performing most poorly and to recruit patients to the regimens that look more likely to succeed, perhaps with the view to transitioning at the end of this study to a more extensive phase 3 trial where we really are trialing target regimens that look like they might be going to work. And that's a possible way without conducting multiple sequential studies that will take forever and without recruiting enormous numbers of patients that will cost a lot, of getting more quickly to a more settled new MDR-TB treatment regimen. So this is the type of approach we will see as new data emerges from MDR-TB trials. There is an element of risk to this approach. When you're going to stop a regimen, you have to be sure that it's the one that's not going to work. And that requires us to have 2 things. It requires us to have biomarkers of response to therapy that can distinguish the patients who are doing well from the patients who are doing badly. Traditionally, we take patients who are sputum culture positive for tuberculosis, and we think the ones that are culture converting to negative more quickly are the ones who are doing well. But at what time point and with what precision continues to cause us problems. We don't have good surrogate markers of long-term outcome that we can identify early in treatment. So that makes this kind of trial design a little bit difficult. And of course, if you're going to base your interim analysis decisions on culture negativity, you have to keep the sample in culture for long periods of time, 6 weeks, 8 weeks, 10 weeks. So your decision-making process is relatively slow. And so we need molecular markers of response to therapy that will enable us to most efficiently implement this type of trial design and selection of new MDR treatment regimens. And we also need a judicious analytical approach. So we need to make the correct statistical decisions on when a regime really is futile in relation to its comparator. And so whilst this is an important and an innovative approach to developing new MDR-TB regimens, it is not straightforward, and the territory continues to be fraught with difficulty. Moving back from clinical trial designs to bedaquiline, it seems to be doing quite well, but where are we still worried about it, and where might it not perform in the clinical field in resource-poor settings? Well, we're obviously worried about toxicity. More people died in the phase 2 study who had bedaquiline than didn't. We're going to need some data to reassure us that that's actually not important. It does prolong the QTC interval, so your risk of arrhythmia may increase, particularly if you're on the drug for a long time. And Bataclan has an extraordinary ability to distribute in tissues surrounding throughout the body, which is good for drug penetration to pockets of disease, but not particularly good at getting rid of the drug if you turn out to have a progressive ECG problem while you're on it. And so a drug that has potential high toxicity and you can't get out of your system very, very quickly has to be introduced with a degree of caution. As with all new medications, perhaps, our data is limited in special populations. So clinical trials are all conducted in people with pulmonary tuberculosis because we can monitor a response to therapy from sputum a bit easier. How will it perform in other forms of extrapulmonary tuberculosis? There will be data, there isn't yet. How does it perform in children? A real bugbear of anyone who's interested in TB therapeutics or in TB at all is that the data in children is much worse than the data in adults. And we need to ensure that as these new drugs come to the market, the pediatric data is as robust as the adult data. Again, it's there, but there's less of it for Bataclan at present. How does it work in other special groups, such as pregnant women, people who are breastfeeding? How does it sit alongside HIV therapy? Bataclan is metabolized in the liver by the cytochrome P450 enzymes, so that means it's subject to interaction with other drugs. It doesn't sit well with rifampicin. A first-line TB treatment regimen with rifampicin and Bataclan in it would have low levels of circulating Bataclan because rifampicin would accelerate its metabolism. And similarly, there are some potential uncertainties surrounding Bataclan exposure in the context of some antiretroviral therapy regimens. We don't really know what the clinical consequence of that is. It's probably going to be easier in drug-resistant disease than in drug-susceptible disease because we're not using rifampicin, which is the real problem in terms of HIV control. But we don't know all the answers for drug-drug interactions yet, and it's also pretty expensive, although its availability in compassionate release programs in resource-poor countries makes it cheaper there than it is in the United Kingdom, where a 6-month course costs about £20,000. Currently, we are only allowed to use Bataclan according to the manufacturer of the drug, according to the WHO, according to the FDA and the other licensing bodies, and even licensing in the UK, out to a period of 6 months. So you give it the first 6 months of an MDR treatment regimen, then you stop it as you would an injectable, because we're not sure that it's safe after that, and then you continue the other drugs to the end of therapy. This is a patient I looked after in a case report that we've just published in the European Respiratory Journal, a 19-year-old Romanian girl. She'd never had tuberculosis before. She presented to us with the first episode of smear-positive disease, and she had an extraordinary resistance profile. We couldn't use any first-line drugs. We couldn't use any rifamycins at all. We couldn't use any injectable agent. We couldn't use any fluoroquinolone. We couldn't use some of the group 4 drugs. We couldn't use prothionamide. We just about got a regimen together. And then we couldn't use some of the other second-line drugs because she developed significant neurological toxicity to linezolid and cycloserine. We applied for Bataclan because at that point it was only available on an individual patient basis in the UK, and we gave it to her for 6 months, and she was doing well. We then wanted to stop it, because that's what you're supposed to do with Bataclan, but we didn't have enough other drugs to give her to complete the regimen. We had azithromycin, which doesn't really work, and we had pyrazinamide, which we continued, even though we had no evidence that it was doing anything whatsoever, and we had pretty much nothing else. And so after a series of fairly fraught discussions with a variety of people, we just decided to continue the Bataclan, and in fact, we ultimately gave her a regimen that contained Bataclan for an entire 18 months of therapy. Now, you can argue whether that was the right or the wrong thing to do. You can argue whether we should have stopped early. But the bottom line is she did manage 18 months of it with no overt toxicity, but with a significant increase in her QTC interval for the latter part of her treatment. And the increase in the QTC interval in her ECG occurred when we also had to add another group 5 drug, clofazimine. So the addition of multiple new agents, or newer repurposed agents, all of which have the potential to be arrhythmiogenic, does make extended treatment more difficult. And that's partly why I show this case, and also partly to highlight that the problem of introducing a new agent for 6 months for the treatment of a disease where you aren't going to have enough sufficient drugs at the 6-month period to know what to do next does create operational difficulties. This girl did very well, but it's an illustration of the point, I think, of how difficult it continues to be to manage multi-drug-resistant tuberculosis. I don't know if I'm going on too long, but I'm just going to keep talking until there's obvious evidence of people falling asleep. The next drug class I want to move on to talk about are the nitromidazoles, and the second new kid on the block. The second drug that we're all excited about is Delamanid. Delamanid is another, like Bataclan, an orally administrable agent, structurally related to metronidazole. It probably inhibits mycolic acid synthesis in the bacterial cell wall. Like Bataclan, it's good against replicating and non-replicating bacteria. Like Bataclan, it's good against drug-susceptible and drug-resistant disease, and the early phase studies support that. It doesn't appear to have any cross-resistance against other currently active classes of anti-TB drugs. It doesn't seem to directly affect some of the hepatic enzymes itself, so it might not have too many drug-drug interactions. And so it may be it also is a drug that has now been provisionally licensed, at least in Europe and Japan and some other places, for the management of difficult multi-drug-resistant tuberculosis. What are the clinical evaluations then of Delamanid so far? We also don't have phase 3 clinical trial data yet. Well, there are basically 3 main reports of Delamanid use. Essentially one big study with different, one big cohort really with different reports of progress across, I think, 17 centres in 9 countries. And a similar approach to Bataclan compared against standard MDR treatment, which is 6 to 8 months intensive phase, 12 to much longer continuation phase, up to more or less 20-month treatment in total. Delamanid given for the first 2 months appears to cause faster culture conversion than the optimized background. So the optimized background plus Delamanid doing better than the optimized background plus placebo. Extension of the Delamanid therapy out to 6 months, a bit like Bataclan, seems to, again, outperform placebo. And then monitoring of patients, just like Bataclan, out to end of therapy, appears to show favorable long-term outcomes. So there's sort of extended phase 2 data to show that if you add Delamanid to optimize background regimen for MDR-TB, you're more likely to get a successful outcome. You're less likely to see death, so there wasn't the same anomaly with the Bataclan studies of higher mortality in the treatment arm. And again, Delamanid moved on the basis of phase 2 studies to accelerated licensing, WHO guidance on use now available, much less worldwide clinical experience of Delamanid use than Bataclan. So Bataclan was the first new drug. Everybody went for the first new drug. Delamanid, there's much less anecdotal evidence or cohort study evidence or compassionate release program data to tell us how Delamanid's doing. What we also know about it, however, from the data that exists, is that patients who only received it for the first 2 months of their MDR regimen did less well than people who received it for longer, did less well than people who received it for 6 months. And in this subgroup of the patients from the currently published Delamanid studies who had XDR-TB, and it wasn't that many people, it was only 50 or 60 people, the same pattern. It seems to result in better treatment outcomes in patients with even extensive drug-resistant profiles, which is perhaps what you might expect, because it's not a fluoroquinolone, it's not an injectable agent, it's purposed. It doesn't have high-level cross-resistance, it's purposed for this type of extensively resistant patients. Again, what are the problems with Delamanid? It's moved to phase 3 clinical trials now. As with all new anti-TB antibiotics, there's a concern about toxicity. There is a concern about QTc prolongation with Delamanid. It's partially metabolized by albumin, and so patients with low serum albumin are thought to be at particular risk. Again, there's a lack of emerging data. It's been less extensively used in compassionate release programs. The clinical trials thus far that have provided us with published data were relatively extensive, but didn't include any centres in sub-Saharan Africa. Only 1% of patients in those trials were HIV infected, and there are no published studies in special populations. It's probably more amenable to combination with antiretroviral therapy. Some abnormalities in some of the PK studies, but generally reassuring. It's also quite expensive. So that's where we are with Bataclan and Delamanid, the 2 main drugs that have entered the drug development pipeline recently. Current guidance not to give them together, and difficulty in knowing how to move from one to the other, particularly if the first drug was Bataclan because of the long washout period. In the same drug class as Delamanid, there's a very similar compound called Pretomanid, which is also in evaluation in a variety of studies. I'm not going to say much about Pretomanid because there's not that much data yet. But what's interesting about the use of this compound, I think, is that the trials that are testing Pretomanid are not testing it alongside optimized background. They're testing it alongside almost entirely novel combinations of medications. So pretomanid, moxifloxacin, and pyrazinamide is in the STAND trial, mainly drug-susceptible TB, one MDR-TB arm. The practical style, which MSF are heavily involved with, trying a variety of pretomanid and Bataclan-containing treatment regimens, leads us to the possible question, are we going to ultimately result in an entirely new unifying TB treatment regimen that will be effective against drug-susceptible and drug-resistant disease? The answer to that question, don't know. So moving on, I'll only talk about 2 new drug classes and then I'll draw to a close. Linezolid is an antibiotic that we've known about for quite a long time. It's a good antibiotic against a whole range of gram-positive infections. It's very active against tuberculosis. We have increasingly already started to use it in clinical practice when other treatment options are limited for the management, particularly of extensively drug-resistant TB. It's still a group 5 drug, but it's certainly a drug with emerging efficacy evidence, and if I had MDR-TB, I'd probably want it rather than some of the oral bacteriostatic agents up front. And there is data, quite impressive data, I think, in patients who have previous treatment and transigent disease who've done quite well with Linezolid. So a South Korean cohort of patients who were not responding to other MDR therapy had Linezolid added, did much better. A clinical trial in China, the graph on the right-hand side of the slide, showing similar results, faster sputum culture conversion in patients who were in Linezolid than on control. What's the problem with Linezolid? It's toxicity. Linezolid, when used to treat other gram-positive infections, for instance, Staphylococcus aureus infection, you give it for 1 or 2 weeks. It sometimes causes a bit of anemia. You can normally manage. 6 months of Linezolid in MDR-TB is difficult for patients to tolerate, and the graph on the right-hand side of the slide shows progressive toxicity in the South Korean cohort. Over half of patients getting significant peripheral neuropathy, also some optic neuritis and some other problems. So patients struggle to continue Linezolid for the intended duration of therapy. The dose of Linezolid given for standard gram-positive infections is quite high, 600 milligrams twice a day. It's possible that we can get away with much less in MDR-TB, and therefore we're able to give it longer, because some of the toxicity might be dose-related. But we don't have the appropriate PK/PD data to know what the best dose of Linezolid is to retain efficacy, continue without not generating drug resistance, and minimize these toxicity and treatment-limiting problems. And there's always talk about new drugs from the oxazolidine class, same class as Linezolid, that will have the efficacy without the toxicity, but so far fairly depressing results from phase 1 and phase 2 studies of those agents. So that's Linezolid, efficacious, difficult to give for the duration required, significant toxicity. And the last compound I'm going to talk about in any detail, I apologize, it's quite a slog and a content-heavy talk. Clofazimine. Clofazimine is a drug we've had for ages. It was developed in Ireland in the 1950s. Initially purposed towards leprosy, more attention towards it now because it's a component of the Bangladesh regimen that I spoke about earlier on. It's a bit like Bataclan in the sense that it doesn't do very well in the early phases of very early bactericidal studies, but when given for a long period of time, it appears to have good sterilizing activity. So it improves long-term treatment outcomes. There's a limited amount or no really rigorous clinical trial data, but there are some retrospective cohort studies showing good outcomes in patients who had clofazimine and added to their MDR-TB regimen. Potential problem with cross-resistance between clofazimine and bedaquiline, which means we sometimes advise giving those 2 drugs together or not at all, and significant issues with toxicity. I showed in an earlier case that the QTc interval jumped up when we add clofazimine to the regimen, so another possibly pro-arrhythmogenic drug alongside the fluoroquinolones or alongside bedaquiline. It's a dye, it causes significant accumulation in the skin. This is the leg of one of our patients who had clofazimine for a long period of time, and she didn't look like that when the treatment started, and it also has a very long half-life. So toxicity concerns, but another group 5 drug that we may choose to use. Lots of phase 3 clinical trials ongoing, and I've sort of tried to signpost the main ones without giving you clinical trial acronym overload. But the key message, I think, is that these aren't going to report for a while. Earliest, maybe 2017, but we are looking at sort of 2019, 2020, 2021 before we get the data. It looks like we've got lots of new drugs, but when you look at the drug development pipeline, there's not very much in phase 1 development. So if the current medications do not work, we may be in trouble again sooner than we would like. There are, of course, other strategies, but I'm out of time and you're probably getting bored. The We sometimes add meropenem, imipenem, that's going back to an injectable agent. I don't particularly like to do that. We sometimes add azithromycin when we're stuck. It doesn't really work. There's interest around host-directed therapy, so not using antibiotics, but using host immune system stimulation. That might be a novel approach, but there's not much hard data to support it. And treatments to supplement the immune response, such as steroids or vitamin D, haven't been overwhelmingly successful in improving MDR-TB or even routine TB treatment so far, with the possible exception of TB meningitis. And in patients who have very localized, heavily resistant disease, so only one bit of the lung affected, we have recourse to surgery to debulk the bacterial load. But that's only really useful in localized disease. And it's not easily transferable to resource-poor settings. You really need a surgeon who can do it and facilities to provide the necessary intensive care support post-operative. But certainly in some settings and in specific circumstances, it's a get-out-of-jail card. So what are the main problems in managing MDR-TB in low-resource settings? I've tried to go through them all, but I'll maybe just summarize them if I have a minute or two just before we finish. How do we cope? It sounds exciting. We've got the Bangladesh regimen, we've got Bataclan, we've got Lamictal, we've got other drugs at a fairly advanced point in the pipeline. They're not going to help us if we can't make the diagnosis better. So how are we going to coordinate new diagnostics with new therapeutics to have a better overall package? At the moment, as a clinician managing MDR-TB, we are in a position of extreme uncertainty. The data is unclear, the trials are ongoing, everyone wants to try their new drug in a PET combination at a PET dose. How is the standard MDR-TB clinician supposed to put a regimen together? And where can we build communities of practice to share experience and to try and have a unified approach to moving forward through this period of drug development and clinical trials? How do we quickly get clinical trial data to make more definitive decisions? Innovative trials design, such as the MAMS design that I showed earlier on, might be one way. How do we balance early access to new drugs like Bataclan against the need for pharmacovigilance? It looks good, but some people died. So when do you introduce it to the clinic? How do we ensure comprehensive access to expensive drugs? Bataclan and Lamictal are not cheap. And mindful of the fact that even with current therapy, patients often don't do well because of logistical factors such as cost of reaching clinic, toxicity, duration of treatment. Even if we get treatment down to 6, 9, 12 months duration, how are we going to utilize our new agents effectively without treatment failures and generation of further resistance? So I probably have gone on a bit, actually, and I apologize. MDR tuberculosis is a major threat to improved tuberculosis control and is a blot in the optimistic landscape that has informed the generation of the NTB strategy. We need new drugs because we need to stop using injectables, we need to be less toxic, and we need to be faster. Although we have new drugs, sustained investment is required because those drugs might not work and the pipeline looks a bit sketchy behind them. And new drugs will only work, I think, when incorporated alongside better diagnostics and the other package of support is required for MDR-TB patients. Resources that I turn to currently are the companion handbook that Dave was slightly disparaging about the complexity of this morning, and it is 400 pages and a bit complicated to use. I use the TB Drug Monograph website because that gives me information of individual drugs that have complex toxicity patterns and that I don't use very, very often, and we await the new MDR-TB treatment guidelines from the WHO, which will probably see the introduction of some of those compounds in a more structured and clear manner. But as you can see, the landscape is currently quite difficult. So I think I've talked for too long. I won't stop.